After thoroughly investigation, we have to arrive at a probable diagnosis. What could be the probable reason of infertility? So, broadly, I have divided a probable cause into a five part. One, ovulatory disturbances, which includes anovulation, hypothyroidism, hyperprolactinemia, diminished ovarian reserve, etc. Another group of patient, they are having tubal problem. It can be a mild tubal problem, it can be severe, it can be occlusive problem, it can be hydrosalpinx, it can be just peritubal adhesions. So various tubal problems are included in this group. The third group is uterine problem. The fibroid, polyp, intrauterine adhesion, cervicitis, maybe endometriosis, pelvic adhesions comes into this category. If the semen is subnormal, then it comes into a male group of problem. And last but not the least, and the most important, is unexplained infertility, where you really cannot point out by just routine investigation, which comprises of history, blood test, and sonography, and if you are not able to arrive the diagnosis, so those group of patients should be included in the unexplained infertility. So broadly, we have divided all the patients into ovulatory disturbances, tubal problem, uterine problem, male problem, or unexplained infertility. After concluding the probable cause, now we have to plan a treatment for our patient. The most important thing to know is what are the absolute indications of IVF. That all the clinicians, whether they are practicing ART or those who want to restrict themselves in a primary care infertility specialist, just want to do ovarian stimulation or maybe IUI or something like that, all must know what are the absolute indications for IVF. Because suppose you are not well aware about the indications of IVF and you keep treating the patient, it will unnecessarily waste patient's money and time without any result. So please be careful and try to understand what are the absolute indications of IVF. To start with, a tubal factor. In any patient, if there is severe distal tubal obstruction or severe peritubal adhesions, this patient should be offered IVF firstly. But if the patient are having moderate problem, not severe type of problem, but the patient's age is around 35, 33, 35, then rather than trying and wasting the time for non-IVF treatment, better to start with IVF treatment. Many times we come across the cases of proximal tubal obstruction. We try with the hysteroscopic cannulation. After trying successful cannulation, if there is no conception after 6 to 12 months of procedure, IVF is recommended. If the cannulation is unsuccessful, then obviously IVF is the choice. There is a condition called salpingitis ischemica nodosa, where the cannulation is contraindicated. So such type of the proximal tubal obstruction patients need IVF. Many times in practice, the patient come for the reversal of the family planning operation. So if such patients are having age more than 35 years, if they are having poor surgical prognosis, meaning they have got short tube, damaged tube, peritubal adhesions, lot of peritubal adhesions. The reverse, abdominal tubectomy was done rather than left TL. So these are the patients who are considered poor surgical prognosis. They should be offered IVF. There are subgroup of patients who are for reversal but they do not want any surgery. They should be offered IVF. The provided the cost of the surgery and one IVF cycle is same, approximately same, and woman is desiring only one pregnancy, then rather than subjecting the patient for tubal reversal surgery, IVF would be a better choice. Now coming to endometriosis. All cases of advanced endometriosis after surgical treatment in older patient should be offered IVF. All cases of advanced endometriosis, if they have coexisting other infertility factors, they should be offered IVF primarily. But cases of mild endometriosis, especially in older women with coexisting infertility factors, IVF would be a better choice. If any case of endometriosis, if medical treatment fails, obviously IVF is the final choice. Now coming to a male factor. If I want to say in nutshell, the IVF is indicated when IUI is not possible, when IUI success is less likely, or IUI is unsuccessful. So what are those cases? Like IUI is not possible. If patient is unable to produce the sample, you cannot do IUI. There is no choice left. We have to use testicular sperm or we have to use other sperm retrieval technique and do IVF. There are certain cases where IUI success is less likely. Like total motile sperm in IUI sample is less than 5 million in old age woman, coexisting infertility factors. These are the poor prognosis patient for IUI. These patients should be offered straightway IVF. When you are trying IUI, the success after consecutive 4 to 6 trial, 90% of the patients who are likely to conceive, they conceive. If they do not conceive, after 6 IUI cycle, they are less likely to conceive further by further trying IUI. So these are the patients where IVF should be offered. When the sperm is produced by surgical method like TISI, TISA, PISA, obviously IVF is the indication. Now coming to ovulatory dysfunction. In cases of PCOS, when control ovarian stimulation with gonadotropin fails, or very bad PCOS, or a lot of gonadotropin consumption is happening, then definitely you would like to try IVF, because ultimately after spending so many rupees, so much for injection, you are offering a treatment of IUI which carries success rate around 10, 12 or maximum 15%. So IVF is indicated in such patient. If the patients are diminished ovarian reserve, especially aged patient, more than 37 years, you should not waste any precious time by wasting on IUI or some other milder treatment. This patient should be offered straightway IVF. Many times you come across a patient of poor ovarian reserve, ovarian failure, premature ovarian failure, and very diminished ovarian reserve, where it is really difficult to conceive woman with her own oocytes, and you require oocyte donation. So in such patient, IVF is the choice. The other indication for IVF are when patient want to preserve the fertility because of some reason, social or maybe professional reason, if she wants to delay or postpone childbearing, and if she requests her fertility preservation, then IVF is offered. Other cases where surrogacy is to be offered for the uterine problem, there is no option but to go for IVF. There are certain patients who are having history of genetically abnormal child or repeated abortions, and who are requiring PGS and PGD. IVF is the final answer and is the treatment of the choice. In next lecture, we will start discussing management option. Thank you.